All right, I do just want to start here, okay, because you kind of have to have these basics down in order to understand everything else. If you have any questions, let me know along the way. I am recording, so try to keep your background noise to a minimum. If you have background noise, I'm going to try to call you out on it. I'm going to stop because I don't want it on the recording for people who want to watch it later. So please try to be conscientious of that. At any time during the recording, if you want to speak, all you have to do if you're on mute is press the space bar and hold it down. Once you do that, it will take you off of mute and allow you to speak. Go ahead and try it. And then when you get done talking, let it go. Everybody knows where the space bar is?
Yes. Yes.
Yes.
Okay, great. All right. So, first things first is the nervous system is your central and your peripheral nervous system. The central nervous system is your brain and your spinal cord, and peripherally, that is going to be the cranial and the spinal nerves. There's 12 cranial nerves, there's 31 spinal nerves. And then you have something like ganglia, which helps with the movement. You have sensory neurons. Sensory means that it's going to send a message to your brain because your brain senses something is going on and it needs to change something. So those sensory neurons, which are actually called afferent, are sending a signal to the cerebral cortex. That's where your processing center is, and it's going to make a decision as what to do once it hits there. Okay. And when the brain wants to send something back out, it uses an efferent signal. Efferent means movement. So whenever your brain sends an efferent signal out, something is going to happen in the body in response to that. So an example is you're in the bathroom curling your hair, okay? Or for my men, your wife left the curling iron on or just unplugged it and you didn't realize it and you grabbed the shaft of it. Okay, curling irons are what?
Hot.
Hot. So what happens when you grab that hot surface? A sensory signal goes to the brain, an afferent sensory signal goes to the brain and says to the brain in that cerebral cortex, hey, brain, this idiot just grabbed something hot. And what your brain say?
Let go of it.
Ouch, that hurts. Let it go. That is your efferent signal now going back out to your hand and causing that reflex to drop it. Now, that doesn't take a long period of time. That happens in a microsecond, except in people who have a decreased sensation or decreased feeling, or maybe their central nervous system isn't working well, or their peripheral nervous system isn't working well. So those signals aren't processing well. Um, so your neuromuscular junctions, this is where muscle actions happen. So, there's a couple of neurotransmitters, acetylcholine being one. That's really one of your main ones that affects your muscles. Okay. This signal is going to be sent, and that's going to cause your muscle to contract. When your muscle contracts, then you can do things with it. All right. Somebody's making me echo who just got on. So please put yourself on mute. Thank you. All right. So at these neuromuscular junctions, these transactions, I'll call them, are happening in order for you to move your muscles, for things to happen. So acetylcholine and other things, other neurotransmitters are going to be released here, and that's going to cause the muscle to work. If the muscle overworks, then it's probably because too much of these neurotransmitters being released for some reason or another. So the brain and the spinal cord make up the central nervous system, okay? And the nerves and the sensory organs make up that peripheral nervous system. Any questions on that? Again, the peripheral nerves, these carry information that are received from receptors out on the peripheral parts of your body. So you stub your toe, ouch. It's going to send a signal. through that afferent or through that sensory nerve, and it's going to end up in that cerebral cortex of the brain. Okay. And then the brain is going to send a signal back out to the body, okay, of some sort, depending on what's happening there. Okay. So it could send a reflex if you're harming yourself by touching something, or it could send a pain signal saying, ouch, that hurt. So it could be chronic pain, acute pain, depending on what's going on there. Those cranial nerves, they connect to the brain and then to the eyes, the ears, other sensory organs like the head, the neck muscles. The 31 pairs of spinal nerves come out from the spinal cord, and they go out to areas like the thorax, the abdomen, and the limbs. Each nerve relays sensory information to the brain, and then it helps send motor commands back, or it can do both. So it might do one or the other or both, depending on what the nerve is. So, like for instance, you have something called a phrenic nerve. That's one of your spinal nerves. Whenever you need to breathe, it stimulates your interthoracic muscles so that they can contract and allow that breathing to happen. It stimulates your diaphragm. Now, your brain is your main communication center. Okay. It's controlling the body. It gets that information mainly at that cerebral cortex. It processes it. It decides what action or response it wants to take, and then it initiates that response. This can be involuntary or voluntary. Okay. So these are both regulated by the autonomic nervous system, sympathetic and parasympathetic systems. Voluntary actions are controlled by somatic nervous system. So the somatic nervous system really controls things that you consciously are able to sense and able to do. And then autonomic controls things that you don't think about. So you don't think about your breathing, right? Your autonomic nervous system is just naturally making that happen. Even when you swallow, like there are certain parts of that swallowing action that are under your control and parts that are not. Different signals that are sent by the brain will control different processes. Your brain interprets each signal. Some of these make you feel tired, others make you feel pain. Some of the messages are kept in the brain. Some are sent out through the spine, through those nerves. And your system relies on these billions of nerve cells or neurons in order for this process to take place. Again, your reflexes are automatic. That's an involuntary response to a stimuli. So when you touch something hot with your hand and then you immediately remove it, remove your hand or drop the object, okay, that's an involuntary response. Some reflexes control visceral activities or posture, okay? Things like when you get up, it'll control your balance. You're not aware of that, but it's happening in your body naturally. And that autonomic nervous system controls, or autonomic motor system controls, any involuntary function or activity of the smooth muscle fiber. So when you think about smooth muscle, always think about action, because whenever your body talks about smooth muscle, some sort of action is going to happen. So the autonomic nervous system that controls your involuntary function is made up of two divisions, sympathetic and parasympathetic. All right, you need to know about the layers of protection for the brain. So you have three main layers. The dura mater, that's the tough outer layer, that's going to be near the bone. And that separates and forms what we call dural sinuses. And these collect cerebral spinal fluid and put it back into circulation. The arachnoid matter, it looks like a spider web. It's the middle layer. And then the pia matter, that is the inner layer. It's very close to the surface of the brain, and this is where a lot of the small blood vessels are found. Now, a couple of other areas that you want to be aware of. The subdural space. This is right beneath the dura, okay? And it's usually empty. But if someone had like a subdural hematoma, they would have blood in that area. So if they fell and hit their head, they could develop blood in that subdural space, okay? And it would be normally called like a subdural hemorrhage, a subdural bleed, a subdural hematoma, something along that line. The subarachnoid space, very important, okay? This is where the cerebral spinal fluid lives. You got to know that. It's right below the arachnoid. So sub means it's underneath. The subarachnoid space contains the cerebral spinal fluid, the cerebral arteries, and the veins. But they're going to ask you about the cerebral spinal fluid. Where does that go? Where is that at? And your answer is going to be where?
Subarachnoid.
Subarachnoid.
Subarachnoid space. Good. You also have arachnoid villi. These are like projections. I call them finger-like projections, okay? And they're in the brain, around the brain, okay? And cerebral spinal fluid can be absorbed for those. So these arachnoid villi can reabsorb that cerebral spinal fluid, and then it goes to the dural sinuses, and then my broca's broken, so we'll talk about that. It goes to the dural sinuses, okay, and then it goes back into circulation. So the fluid itself is in the subarachnoid space, that cerebral spinal fluid. The arachnoid villi will suck it up, send it to those dural sinuses, and those dural sinuses put that cerebral spinal fluid back into circulation. That's a very important part of the brain function. Anybody know why?
To keep our brains lubricated.
Okay, so the cerebral spinal fluid, it keeps your brain lubricated, but it's much more than that.
It cushions it.
Okay, it provides a cushioning. What else?
Does it protect the brain from infection?
So it doesn't really protect the brain from infection because its job is to provide nutrients, okay, to the brain. And we're going to go over what's in the cerebral spinal fluid. But the reason why it's so important that the fluid is collected and returned to circulation, because that's what I'm asking you about, is because in the brain, you have a very small amount of space. Now, how many of you have ever seen a baby that has something called hydrocephalus? Or
I
ever
do. My
seen
daughter had it.
okay. Or seen a picture of it? Is there anybody on here that's never even seen a picture of it? So if you notice a baby's brain, when they have hydrocephalus, the brain, the head, the whole thing becomes elongated and puffy, and it sticks up really high. Who's seen that movie, The Coneheads?
Yes, I see.
Yeah.
So the brain kind of looks like that, but it's not shaped in a cone, right? It goes really high like that, but it's not shaped in a cone. Now, why? Because babies don't have bones formed there yet. But in an adult, you have bones there. So that brain cannot expand like that. So what happens is at the bottom of the brain is your brain stem, and actually you'll have a blowout there. So when you have ICP and someone does have that increased pressure, okay, you're going to start to see symptoms that are related with what happens in that brain stem. And we'll talk about that when we get to ICP. But that's why you have complications there, because the fluid's being pushed down. If we have too much fluid in the brain, there is nowhere for it to go because of the bones. So the point is, this circulation process has to happen. If anything interferes with this circulation process, we're going to have a problem with increased pressure in the brain. Any questions on any of that?
So the key points of the cerebral spinal fluid is that it circulates basically to control the pressure.
Yes. It helps control your ICP. It's bringing nutrients. Well, it doesn't control your ICP. Let's say it this way. We monitor it for intracranial pressure. So don't add the control part, because it doesn't control intracranial pressure, because there's a lot of things that can affect the cerebral spinal fluid. What it does is it maintains the pressure if everything else is intact. So by constantly reabsorbing, okay, that's how we're maintaining the pressure, by reabsorbing, putting it back into circulation. There are other things that can happen in the body that could affect that fluid, or parts of the brain, like tumors and things like that, that can put pressure in the brain. We'll talk about that. Okay. And if that happens, that can affect that fluid that's flowing through. But it's not because of the fluid, it's because of what else is happening in the brain that's displacing the fluid. Got it?
Yes.
Okay. Let me plug this other computer in before it dies. All right. The meninges, these are the three membranes that cover and protect the brain. Again, those are the dura mater, the arachnoid matter, and the pia mater. And those meninges protect and anchor the brain. They give a support system for the blood vessels, the nerves, your lymphatic fluid, your cerebral spinal fluid, everything that surrounds your central nervous system. So there you go. When I asked you, what does the cerebral spinal fluid do? Here you go. Okay. So it does provide a cushion for the brain and the spinal cord. It's similar to plasma, but the electrolytes, the glucose, the protein concentrations are not the same as they are in blood. You don't really have to know what they are. You just have to know what would you see in it versus what you would not see. And we'll talk about that in a minute. And we'll look at the cerebral spinal fluid. So that's why we do the lumbar puncture. Okay. You take the spinal fluid out and we'll look at it and we'll measure it for pressure. Okay. It needs to be reabsorbed in order to maintain intracranial pressure. It flows through the ventricles in that subarachnoid space, and it's made in the choroid plexus of the ventricles. And these are in your third and fourth ventricles, okay? Probably won't see a question about that, but I'd like you to know it's made there. I would like you to know that it's in that subarachnoid space, that it has to be equal amounts reabsorbed and produced in order for the pressure to be maintained. So if any process in the brain interferes with that, it's going to cause a problem with your pressure. You should know what is normally in it. So how many of you have ever treated a patient with a head injury that's had a runny substance coming out of their nose or their ear? What we'll do is we'll take a 4x4, we'll put it under the nose or by the ear, and we'll collect that fluid. Okay. Usually, if someone has some sort of a fracture, a skull fracture, on that fluid, we'll see a what we call a concentra ring, which indicates that they have some sort of an issue. Okay. They have some sort of fluid leakage from the brain. So we test the intracranial fluid for glucose. We'll also look for protein because it should not have high amounts of protein in it. It also should not have red blood cells in it. but we will see a little bit of glucose and a little bit of some of the other electrolytes in there, like sodium. So it should be clear when we take it out. If it's cloudy, then we probably have an infection. We'll look for significant amounts of red blood cells. If someone had that, then we would look further at the brain to see if they have some sort of a bleed. We'll look at protein, we'll look at glucose, okay? And we could actually stain the fluid if we were looking for something like meningitis or some other infection to try to rule out why someone is having an issue. So these are things that would help us. We'll look at that fluid. It can help us diagnose. All right. Remember I said the third and fourth ventricles, that's where the choroid plexus is. That is where that cerebrospinal fluid is actually made. This is the characteristics of the cerebrospinal fluid, okay? You don't have to know exact amounts here, okay? What you have to know is it's usually clear and colorless. So if it's not, then we probably have an infection. There should not be red blood cells in there. We might have a few white blood cells. We will see protein, glucose, potassium in there. Okay? That's what you need to know there. Your brain has a couple of barriers that protect it, okay? The blood-brain barrier. So here, it doesn't allow certain things to cross over. And it controls the balance of the electrolytes, the glucose, the proteins. It's very tightly joined together, okay? So it has very limited permeability. Remember, we talk about increased capillary permeability allows things to slip through. This is really tight, so it prevents things from slipping through. Why? Because we don't want to cause brain damage to someone. So that's a great function, and it controls the delicate essential balance of those electrolytes, the glucose, and the proteins. You also have a blood cerebrospinal fluid barrier that also helps with that to protect it. Now, in babies, the blood-brain barrier is not very well developed. So when a baby has jaundice, how many of you are familiar with that?
Yeah.
Yeah.
Okay, what is jaundice? What's happening in the body?
Isn't it a
Low
lack?
bilirubin.
It's either a buildup of bilirubin or a lack of it.
It's too much bilirubin. Okay. Too much. Okay. It's an increase in bilirubin. Now, bilirubin is usually broke down by the liver. Okay. And it becomes in a form that the body can get rid of it. In some cases, the body can't get rid of it and it builds up. In babies, it can cross that blood brain barrier and it can cause something called kernicterus. I would know that. And that is going to cause brain damage. So it's too much bilirubin in the brain. Kernicterus, okay, is the name of it. It's in your book. All right. And this is when bilirubin or anything else that's toxic, can cross into the baby's brain here. The other thing about the blood-brain barrier is sometimes it's a disadvantage because we might want to give somebody a specific treatment for cancer or an antibiotic because of an infection. And because of that blood-brain barrier, we can't use some of these essential drugs because they won't cross over and take care of that infection or that tumor in the brain because of that barrier. So it can be good and bad depending on what your issue is. Things like alcohol can easily cross the blood-brain barrier. That's important to know because when you see these young college students, all right, not my nursing students, but the ones that are going to places like Penn State, okay, what's their normal night exist of? Consuming alcohol. And what they don't have a lot of is food. And if they have to choose between the food and the alcohol, they're probably going to choose the alcohol. Okay. When you don't eat, alcohol is also easily able to penetrate in through the stomach, okay, and into your bloodstream. So now they go to like a frat party. They didn't eat. They go to this frat party and they're being inducted into the Hall of Frat. Okay. And what do these frat brothers want them to do? Drink, 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 drink. Okay. And they're drinking shots of things like 150 proof grain alcohol. It literally could take about 7 shots here to kill someone because you have 150 proof grain alcohol, nothing in the stomach. Your parents say before you drink, eat. While you're drinking, eat. After you drink, eat. Why? It delays the absorption of that alcohol. So here we've not eaten anything, or bare minimum, we're still not eating anything. We're consuming this large amount of alcohol. It easily crosses into the bloodstream from the stomach, and now it hits the brain. Okay. And what does alcohol do to the brain?
It slows your like thinking process. It like limits your inhibition. It throws off like
Why?
right.
Why?
Uh,
Yes. Yes. Right.
be,
Dehydration.
No.
is is some. It probably has something with the blood-brain barrier and like the way the alcohol like affects the blood.
So it can cross over the blood brain barrier. We already said that. But what does alcohol in general do to your body? So let's think about this. Okay. Why can't you take
It's the
alcohol
depression
and benzodiazepines together?
because it
Why did they?
suppresses the
Go ahead. It
it
depresses what?
suppresses
Um, the nervous system, like your
Yes, your
responses to
central
everything.
nervous system.
Gotcha.
It depresses your central nervous system. Okay. So that is going to affect what? Because we're about to talk about that.
Everything, like your breathing, your
Yes, your
thinking,
breathing, your
your
heart. Well, thinking doesn't matter. Okay. If you
yeah,
you could
okay.
be a dumbass, that ain't going to kill you to be a dumbass, right?
That's true.
What is going to kill you? Your
The
respiratory, your
decreased
heart
heart
rate,
rate.
your basic functions, your basic life sustaining functions. So that's why it's a problem that it affects. Now, people might not make very wise decisions. They might run out into traffic or drive a car and hit something and not even know that they did it. Okay. You see them on TikTok and on cops, I'm sure. All right.
Yes.
It's going to affect the brain in that way also. But I mean, that would kill you if you did something dangerous. But really, what could also kill you is the depression of that central nervous system that is controlling those life sustaining functions like your heart rate, your breathing. Okay. 2 parts of the brain, the left and the right. And you also have a part in your body where your nerves are going to cross over. Okay. And when that happens, then we have one side of the brain controlling the other and vice versa. So in the left hemisphere, you have the frontal lobe, parietal lobe, occipital lobe. In the right hemisphere, look over here, you have your cerebrum, your cerebellum. Okay. Your spinal cord is down there at the bottom, and your brain stem. So just look at those different parts of the brain. Now, what we're going to really talk about here is what part of the brain controls what part of the body and how is it affected. Why do you need to know that? If someone has an injury to the frontal lobe, you need to know how it's going to affect them. Okay. If someone has an injury to the cerebellum, you need to know how is it going to affect them. All right, so the cerebral hemispheres make up the largest parts of the brain. There's a longitudinal fissure that separates left and right, and then they're divided into 4 lobes. Your diencephalon, that's the central portion. That's going to have the thalamus, the hypothalamus, and the epithalamus. And really, your hypothalamus, that's your relay center. We've already talked about that a little bit when you talk about fight or flight and other things that are happening in the body, like ADH. Okay. That's all your hypothalamus sending out those
That
relay signals for the body to do certain things. Now, your brain stem, this is the connecting link to the spinal cord. And in that brain stem, please put yourself on mute. You have the midbrain, the pons, and the medulla oblongata. The cerebellum is going to be right below the pons, and the medulla right below the occipital lobe. All right, so the cerebellum is at the back of the brain below the cerebrum. It coordinates your voluntary movement like posture, balance, coordination, and speech. I would know that. If someone has a problem with the cerebellum, they're going to have a problem with balance, movements, or coordinating their muscles. The brain stem is the lower part of the brain. Again, it helps connect to the spinal cord. In there is the midbrain, the pons, the medulla oblongata. This controls the life-sustaining function like heart rate, breathing, sleeping, and eating. Any damage to the brainstem could result in a life-threatening condition like difficulty breathing, difficulty controlling your heart, and loss of consciousness. All right, so this slide is just showing you how the right and left hemisphere are. They look alike, but they're not the same when it comes to function. So for most people, the dominant side of the brain is the side that controls their language. And for most people, that's the left side. Okay, it's also responsible for solving mathematical problems, logic, reasoning. Your right hemisphere, I call my Prince side. Okay, because Prince was the artiste, right? He was creative. So this is your artistic abilities, your creativity, your spatial relationships, as well as emotional and behavioral characteristics. All right, I'm going to switch over here now to another slide for a minute. Let me know when you can see it. Can you see the new slide now?
Yes.
Yeah.
yes.
Okay, so again, if you look at the left versus the right, what do you see? The left side is mostly about logic, reasoning, being able to read, write, think, being aware of time. And look, the left side controls the right side of the body. On the right side, it's more about abstract spatial relationships, music, art, and awareness, and that controls the left side of the body. Okay, so when you look at the bottom, it shows you right there Okay. And you can feel free to take a picture of this, but I am recording this for you. All right. Injuries on the left side of the brain. How are they going to affect me? You should know that. Okay. Versus injuries on the right side of the brain. So on the left side of the brain, we see difficulty with understanding both spoken and written language, difficulty with being able to express. And that has to do with your Broca and your Wernicke's area that we're going to talk about. It can affect your speech. It can affect your memory. On the right side, we have impairment in the attention. So sometimes you'll neglect. Okay. And if it affects the left side of the body, then that's the side of the body that you're neglecting. Decreased awareness of those deficits. So you don't even know that they exist. And then you'll have altered ability to be creative or even produce music. So now I just want to go back and recap a little bit, okay? So that cerebral spinal fluid, it's going to help cushion the brain and the spinal cord, should be clear. It'll have some electrolytes, some glucose, some protein, some occasional white blood cells, and it's a little bit acidic. Any changes in the characteristic of it would be used to analyze a person for increased cranial pressure. We'll look for infection. We'll look for bleeding. Okay. So we look at that by looking at the pressure, how it looks should be clear, colorless. If there's any protein in it, if there's glucose in it. Again, it's formed by that choroid plexus, flows to the ventricles in the subarachnoid space. Equal amounts have to be produced at all times in order to maintain that pressure. The brain stem is forming the connection between the brain and the spinal cord. You have the midbrain, the pons, and the medulla oblongata. These are controlling those life-sustaining functions, okay, like breathing, heart rate, blood pressure. This is your medulla oblongata. Okay, it contains the vital control centers that regulate respiratory, cardiovascular, and coordinates reflexes like the cough reflex, swallowing, and vomiting. So when someone has increased intracranial pressure, one of the things that happens to them is they'll have projectile vomiting without any food. And they have that because here your emesis center is. And that increased cranial pressure from that extra fluid in the brain is pushing down on that emesis center, and it causes them to vomit. And it's like exorcist vomiting. Y'all know what I mean by that?
Yes.
Yes.
Okay. The only other time you'll ever see that, and you'll talk about this when you get to digestive system, is in something called pyloric stenosis. When your pyloric area is stenosed, that little valve that's supposed to help food move through. So you'll see it in babies, but that is induced by food. This one is not induced by food. They might ask you about it. All right. So increased cranial pressure pushing down on that emesis center there causes people to throw up and have that projectile vomiting. All right. But the main thing about this medulla oblongata is, one, there's a lot of cranial nerves coming into that area. So cranial nerves go out to the body and control different things. Okay. Like your eyes. All right. Your ability to swallow. Your ability to stick your tongue out. Your facial nerves, your hearing. So all those are controlled by your cranial nerves. Your medulla oblongata also controls automatic processes that you don't have to think about, like coughing, sneezing, swallowing, vomiting, and helping you maintain your balance along with the inner ear. So when people have fluid in their ears, a lot of times they can't maintain their balance. this medulla oblongata is helping control that. Okay. Again, if it's not working, then something's probably broken. Most of your cranial nerves converge or go through the medulla oblongata, and then they connect to other areas like your throat, your tongue. Okay. And then there's something there called a crossover point. All right. And you have pyramids there. And this is where the nerves cross over to go to the opposite side of the body. All right. So this is called the point of decussation or decussation of the pyramids. If you look at the bottom of the screen there. Okay. So, and look at the picture. You see how it crosses over now? It's coming from the right side of the brain and going to the left side of the body and vice versa. Okay, so the pyramid fibers cross over to the other side of the body, and that's how each hemisphere is able to control the voluntary movement on the opposite side of the body. You also have something there called the cortical spinal tract, known as a pyramidal tract. Okay, these carry information from the cerebral cortex out to the spinal cord for movement to happen. So it's sending signals along those pathways for movement related information from the brain to the spinal cord. And once it hits the spinal cord, if the spinal cord is working right, it can cause that muscle or that body part to move or to engage in some sort of activity. Okay, so neurons that travel in that cortical spinal tract are called upper motor neurons. And they'll make contact with the skeletal muscle to cause those muscle contractions. All right, the cerebellum is going to be dorsal to the pons and the medulla. Again, that's helping with movement and posture. So it's helping control your equilibrium. And it adjusts to input from the pyramidal system to the proprioceptors in the joints and the muscles. So remember, I said you have incoming signals. Those incoming signals will go to the brain. They sense the movement. Okay. And then the outgoing signal goes back out to the body and it controls that posture or that movement. So people that have damage to the cerebellum, okay, will have a problem with balance when they stand, when they walk. They also could have a problem with reaching for objects. Okay. So we call that proprioception. So if you notice, like old people, a lot of times when they fall, when do they fall? What are they doing when they fall?
Reaching for something.
Okay. Sometimes they reach for something, they miss the something, and it throws them off of balance. What else?
Walking.
Okay. But what in particular are they doing when they're walking that causes them to fall?
Looking down.
Or going
Hand-eye
down a
coordination.
step. They're going down a step, right? Now, how many times have you ever went to step down on a step and you thought you were on the step, but you weren't? And what
Too
happened?
many times.
You busted
You
your butt,
like
right?
trip. Yeah.
Okay. So a lot of times they sense or they feel like their foot is where it's supposed to be. And it could be a really small step sometimes, like just a little ledge. And you notice like they'll fumble and fall because they don't have good control there. You'll see this in patients that may have had some sort of brain injury, some sort of stroke that affected this part of the brain. Or they could have a tumor or a lesion on the brain in a specific area that affects this. All right, before we get into these, I just want to talk a little bit about one more thing. So let me stop this here and go back to the other slide. We are going to talk about on this. Can you see this new slide?
Yes.
Yeah, it's
Yes.
just small.
Okay, let me make it bigger. We are going to talk a little bit later about Broca's area and Wernicke's area. Those have to do, and you have to know those and what sort of aphasia that they cause. But before we go on to that, I just want to talk about the blood supply. Again, all these they might ask you about, but it's more likely that the stuff I'm going to reinforce to you is what you're going to see. But your prefrontal cortex, that's your cognitive behavior, personality. Basal nuclei, this has to do with movement. Okay. So you see how it says part of the extra pyramidal system? How many of you give
Yes.
psychotropics to patients? Anybody give psychiatric drugs?
Like
A
lithium.
couple.
Okay. So in people that take psychiatric drugs, especially the older type, the atypical psychiatric drugs that we used to give people, like Haldol, there's some other ones, okay? We would give them mostly for people that have things like schizophrenia, okay? And if you give these type of drugs or drugs that cause EPS is a symptom they'll sometimes develop from the drugs, which is movements that they're not supposed to have. Okay. So when you think about basal nuclei, when you think about the extrapyramidal system, think about movement. Look at what it says there. Control and coordinate skeletal muscle activity. Now, how many of you know what an Ames form is? Anybody? So when you give these drugs as a nurse, we have to document something called abnormal involuntary movement. And that's what's happening here. So when you give people certain drugs, you'll see commercials for this. Okay. Tardive dyskinesia, you know what that is? See the commercials
Yes,
for it?
that's
Yes.
involuntary like movement.
Exactly. And extrapyramidal symptoms, because eventually, first they'll develop the EPS, eventually to become that tardive dyskinesia from long time use of these psychotropic drugs. So just to make it simple but quick, okay, back in the day when someone had schizophrenia, they would give them a drug that would target dopamine. That basal nuclei and that dopamine are all in the same area, okay? And it would really target that area. And what would happen is it would help with some of the symptoms of the schizophrenia, but it would cause them to have these abnormal movements. So they tried to fix that. And now they give them what we call typical antipsychotics, which target both dopamine and serotonin. And it has somewhat decreased these adverse effects of these extrapyramidal movements. Okay. Or the tardive dyskinesia, which they'll develop eventually. So you'll see it in things like they'll roll their fingers all the time. They'll push their tongue out. Okay. They do weird movements. They'll shuffle their feet. All right. So when you think about the basal ganglia and extrapyramidal system, it all goes together with that skeletal muscle. And sometimes that's affected by some drugs people take. Hopefully that'll help you remember it and what it is. The limbic system, this is your emotions, okay, or your feelings. So when you talk about the limbic system, that's what they're talking about, emotions or feelings. If they ask you about that area, mostly that's what it's going to be about. All right, I already talked to you about the hypothalamus and told you that's a relay system. Okay, look what it's maintaining there. It's sending out messages, or it's sending out hormones, or it's triggering neurotransmitters to control things in the body. Okay. It has a lot to do with your endocrine system. It has to do with your body fluid temperature, your fluid and food intake. Okay. Because it's also going to help with some of that thyroid control, which is metabolism. All right. Regulation of the sleep cycle, your stress response. If you go through here and just look at this slide, this just tells you all the things that hypothalamus does. All right. So it controls the temperature in the body. It can make you shiver or make you cool off. Remember, we talked about temperature last week, right? When I talked about infection, about how the body will set a higher temperature point, the hypothalamus specifically, when someone has a fever. And when it does that, it causes you to shiver or cool off by sweating. So once you take the medication, remember, it went from the shivering to cooling you off now and resetting the thermal point. Everybody remember that? So it's just
Yeah.
talking about the same thing here. Okay. We also talk about how it generates thirst through the osmo receptors there, right? And that will, when you're thirsty or you don't have enough fluid, it's going to cause your body to produce ADH because that hypothalamus is going to be triggered through those thirst receptors first. And then it's going to send that signal to the pituitary gland to release that ADH to conserve fluid. It helps with the hippocampus. The hippocampus is like, think about this as a big hippo that's in your brain, and it's a big hippopotamus, and it walks around campus and it collects all your new knowledge and information you need for the nursing exam. So it's helping you form new memories as we speak about your knowledge about the nervous system. Physical reactions in the body it can cause because of emotional responses, because there's a close communication between the hypothalamus and the limbic system. Remember the limbic system. It causes change in response to emotions and feelings. So if you're angry because of this close relation with the limbic system and the hypothalamus, anger can lead to things like increases in the blood pressure and the heart rate. It also helps control your sleep wake cycle. I guarantee you they'll probably ask you something about the hypothalamus. Okay. And then the reward pathways in the brain. Okay. These are pathways that you have. This again goes back to that dopamine center. Okay. So people that take cocaine, and I'm going to use that because this is why they become addicted. Because when they take the cocaine, it produces a feeling of goodness. Okay. And so it causes this reward pathway to be activated. They experience the pleasure from that cocaine, and it makes them want to take it again because the brain remembers that. But this also is an important part of things that you do on a normal basis. Like you eat and you want to go back to a restaurant again. Why? Because they had really good food and your mouth starts to salivate. Or you don't want to go back there at all because it was horrible. Or again, when you engage in sexual activity, you try something new, it brings you an experience of pleasure, and your brain wants to do it again. All right. One thing I want you to be aware of here is reticular activating system. Your reticular activating system is your arousal area. Okay. I call it the RAS, RAS. The RAS will arouse your S. So when your RAS is working appropriately, it's going to increase your level of awareness. Okay, the reticular activating system determines the degree of arousal or awareness in the cerebral cortex. It also helps decide what incoming sensory impulses the brain would ignore and what it would notice. So sometimes people take certain drugs that could affect that RAS. And the RAS also ensures that the brain doesn't have too much information to process or more than what it can handle. The RAS is located in the midbrain. Okay. Again, it determines the degree of awareness in that cerebral cortex. Drugs can affect the activity of it, either increasing or decreasing the input to the cerebral cortex and the diencephalon. All right, now let's go back to our other slide here. All right, and I'm just gonna let me know when you can see it. Can you see it, neurotransmitters?
Yes.
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 Okay. All right, so acetylcholine, all right, this is present at the neuromuscular junctions that I talked about a little bit ago. You also find it in the autonomic system, sometimes in the peripheral nervous system. Okay. And it is going to help with muscle contractions. Now, whenever you look at a neurotransmitter, okay, they do certain things. Like this one is excitatory. So it's going to make something happen in the body. It's going to increase the response in the body. Okay. Inhibitory means it inhibits some sort of response in the body or the brain. Catecholamines include norepinephrine, epinephrine, and dopamine, and these are all in the brain. Norepinephrine is also in the sympathetic nervous system. Both norepinephrine and epinephrine released from the adrenal medulla, and you have to know that, will be released in response to sympathetic nervous system stimulation, so fight or flight. Then they circulate in the blood and the interstitial fluid, okay? And eventually they'll stimulate the receptors in the sympathetic nervous system and cause things to happen. Serotonin is involved in mood, emotions, and sleep. So a lot of times when people have a problem with their serotonin, okay, it's an excitatory neuron. So they'll be depressed. Dopamine too. Too much dopamine usually is schizophrenia. All right, the next one is GABA, and GABA is inhibitory. So when people don't have enough GABA, they're subject to things like anxiety and seizures. Okay. Gabapentin is a drug that can help. Okay. We can increase the GABA levels in the body, and that can help with the inhibitory process. I like to relate GABA to Fred Flintstone. Okay. Fred Flintstone's always relaxed, right? He's always a cool cat. So Fred Flintstone says what? Gabba dabba doo. I'm relaxed. How about you? So when we don't have enough GABA, that person's going to have things like anxiety and probably seizure disorders. And then glycine is the most common inhibitory neurotransmitter in the spinal cord. All right. And they study these constantly in mental health disorders. Okay. So for low levels of norepinephrine, dopamine, these can be linked to depression. They use drugs that try to work off the same inhibitory or excitatory way that these neurotransmitters do. So they'll try to increase the GABA levels in someone that has seizures or anxiety, okay, in order to correct that issue. Same thing with serotonin. What we give them is serotonin. SSRIs is one thing, serotonin reuptake inhibitors. So it stops the body from reuptaking the serotonin. And that means it allows more serotonin to be available to go out to the peripheral nervous system. Okay. So it stops the body, because what happens is the neurotransmitter releases the serotonin. Okay. The body will have a certain amount available, and the rest the body takes back up and destroys. So what it does is it stops that process of being able to take it back up and destroy it, and it allows the serotonin to stay out there longer so the body can use more of it. That's what an SSRI does. Just so you understand. Any questions on any of that?
Yes, can you
I
repeat where you said the norepinephrine and epinephrine is released from?
Yes, the adrenal medulla.
Thank you.
Any other questions?
I can you just clarify because in Miss V slides it had like the GABA and the glycine flipped. So the glycine is the most common in
Let
the
me just look it up and make sure, okay, that
okay.
I have this right. Maybe I did put a typo in there, but I don't think so, but I'm gonna look. So I guess got to open my Evolve account here, and I'm gonna pull it from the book.
No, it could be the wording too. Is it
No,
just
it
that
says that in the
GABA
book from the spinal cord. I just checked the book. That's what it says. Glycemia is from the spinal cord. Cord,
spinal cord
okay.
and then GABA is just like the
From the
most
brain.
in,
It's mostly
Brain,
in the
of
yeah.
the
brain.
brain? Okay.
Yeah.
It's in the book. It's in the book too.
Okay.
All right,
Listen,
thank
I
you.
make sometimes slides at 5 o'clock in the morning, and I'm human, so sometimes I do make some errors. If you ever see an error on the Cahoots or the slide, please let me know so we can correct it for you guys. All right, so this slide I just put on here just so you guys can see a little bit about, how does it affect the body? So the acetylcholine, the main thing you want to know is that it helps with that muscle action, okay? In people with Alzheimer's, the reason why they have such a memory problem is because that acetylcholine also helps with memory, and it's rapidly depleted because the neurons that produce the acetylcholine in someone with Alzheimer's are breaking down or deteriorating for some reason. So that's why they have such a problem with their memory. Dopamine, again, most of the time when you talk about dopamine, they're going to be talking about either depression or schizophrenia. Okay. So that's where you'll really hear about it. Too much dopamine is going to be a problem for people that have schizophrenia. Also, the body doesn't use the dopamine right in Parkinson's. So they'll take something called carbo-levodopa, which helps distribute it better. It's just not distributing the neurotransmitters correctly. And so they'll also have a problem too with memory and mostly movement. If movement of their face, movement of the ability to swallow, they shuffle their feet, right? All things you see in someone with Parkinson's. Too much dopamine is going to make you scribble scrabble and very unorganized. So that's what we see in clients with schizophrenia. Serotonin, this is mostly related to depression, okay? It's going to affect your mood. And sometimes when people are depressed, they can't eat or they eat too much. Also, you see sleep and arousal. So people that are depressed, what do they do most of the time? They either sleep too much or not enough. Norepinephrine, again, in the emergency room, we call this levo-fed or leave them dead. So this is one of the last line drugs that they might use to try to arouse someone, to wake them up. Okay, norepinephrine. So it helps arouse through the RAS, reticular activating system, and the RAS will arouse your ass. And then GABA, this is inhibitory. Okay, so you see if we don't have enough, we can develop seizures or insomnia, anxiety. So GABA dabba do. Fred Flintstone's relaxed. How about you? Fred Flintstone's relaxed because he has enough GABA. If he didn't have enough, he could have seizures or insomnia. All right. And then the last one on here is glutamate, but in your book, they use glycine, and that is released from the spinal cord. But I just kind of put this up. If you look on the left, it kind of shows you, hey, epinephrine is fight or flight from the adrenal medulla. And what's going to happen? We're going to have an increase in the heart rate, the blood pressure. So how do these two systems work? They work against each other, parasympathetic and sympathetic. Okay. So they have opposite effects. All right. Remember, in sympathetic, we're in fight or flight. So our pupils are dilated because we need more blood flow coming in, and more light coming into the eye area so that we can see better, especially in dim light. Okay. Inhibits saliva. So we talked about saliva being part of the digestive process, right? So here we don't want to rest and digest because we don't want to crap our pants while we're running for the bear. We can wait till we get in the house and do that. It dilates the bronchi. Why? To bring in more oxygen, not only for the lungs, but the brain is going to need more oxygen here. It increases your heart rate. Again, anything that has to do with digestive, it's going to inhibit it. It stimulates the adrenal medulla. The adrenal medulla is going to release what?
Norepinephrine or epinephrine.
Yes. And it relaxes the urinary bladder. It can stimulate the orgasm in the man or the woman. So parasympathetic we see is going to be the opposite. Pupils are now constricted. The saliva is going to increase because we want to rest and digest. The heart rate's going to slow down. We want to rest. We don't need as much oxygen here because we're not using all that energy. All right. And now our activity of the pancreas, the gallbladder can increase. Constriction of the urinary bladder and erection of the genitals of the man and the woman. So again, if you're relaxed, okay, that function can happen, right? All right. Now, this is talking about different things that affect the brain. Okay. So a lot of different things can affect the brain. And one of them is supratentorial and infratentorial. So these lesions really are, where are they? So infratentorial is going to be down in the brainstem below that part of the brain, and supra is going to be higher. And they're important because they help control the lower and upper motor neurons. Okay, so that's how it's going to affect the brain. If you have an infratentorial lesion, remember that's in the brainstem. So if it's in the brainstem, how would that affect us? What else is in the brainstem? Respiratory function, circulatory function, because it's controlling breathing, heart rate, blood pressure, your RAS, your reticular activating system. So it's going to affect your level of consciousness. Okay. Local effects are signs that are related to a specific area of the brain or the spinal cord where the lesion or the trauma is located. So an example would be damage to a section of the left frontal lobe that would lead to paresis or paralysis of the right arm. Expanding lesions are usually caused by a tumor or a hemorrhage, and then we'll have other areas that are involved as the impairment occurs. With an expanding lesion like a growing tumor or a hemorrhage, we'll see additional impairment in the adjacent areas. So again, this is just showing you the different parts of the brain, all right, what they control. So depending on where the injury or the lesion is, how is it going to affect them? So damage to the left hemisphere will affect your ability to logically think, your analytical skills, communication skills. Damage to the right side of the brain is going to impair your appreciation of music and art. It can lead to behavioral problems, self deficits, spatial orientation issues. So you definitely want to know that. And again, the left side versus the right side. What are we going to see? Okay. An injury on the left side is going to cause a problem with language, speaking it or writing it, expression, speaking it or writing it, changes in speech, changes in your verbal memory. So, meaning you might not remember a word, impaired logic. And then on the right side, we see impairments in attention, neglecting the left side, memory issues, decreased awareness of your deficits, not being able to think, abstract, and altered creativity or music perception. Okay, this is another thing that you have to know. You have to know vegetative state versus locked in syndrome. Okay, so in a vegetative state, we lose awareness and mental capabilities, but the brain stem is still working. So our body is still breathing, our heart is still beating, and we'll have some of those autonomic functions still working. The person may look like they're in a sleep wake cycle. But if you took like a pin, okay, or if you walked into a room, they might not be aware of your presence. They might not feel the pin sticking them in the leg. Locked in syndrome, they're aware and capable of thinking, but they're paralyzed and they cannot communicate, talk, or move. They can blink their eyes in this condition, though. They probably won't ask you about that. The main thing I want you to know is that they're aware and capable of thinking, but they're paralyzed, okay? So they're not able to communicate. Any questions about that?
No.
Okay. You also have to know these 4 things for the brain death criteria. Okay. So they'll have cessation of brain functioning, and we can measure that with the EEG. So on that EEG, we're not going to see any movement. It's going to be flat or inactive. And again, this is function of the cerebral cortex and the brainstem. They won't have brainstem reflexes or responses. No spontaneous respiration. So if they're on a ventilator and we remove it, it won't automatically kick in. And we'll have irreversible confirmation of irreversible brain damage. Usually that requires evaluation by 2 different doctors. And we have to be careful because sometimes when people take a drug overdose or they're subject to hypothermia, it can make it look like they're brain dead. But if we resolve those issues, they may come back to awareness. So that's why 2 physicians. You have to know the difference between the posturing, okay? Corticate versus decerebrate. So with corticate, it moves towards the core, okay? Arms move like a C towards the core. With decerebrate, the arms move like E's. These are problems with the midbrain or the pons. That's life-sustaining. Decorticate is problems with the cervical spinal tract or the cerebral hemisphere. Another one they like to ask you about is hominis hemaniopsia. Okay, so here we have a visual loss on the same side in both eyes. And when you look at the picture on the bottom, okay, that's what it's going to look like. They'll only see one half of the picture there. It's usually caused by damage to the brain from a stroke or an injury. And it could be either on the left or the right side, depending on where the damage is in the brain. Remember, if the lesion is on the left side, it's going to affect the right side. The lesion's on the right side, it's going to affect the left side. And they won't be able to see objects on the affected side. Next is aphasia. So with this, they cannot comprehend or express language. There's 3 types. We're going to talk about them. Okay, you have to know these. So aphasia itself is they cannot comprehend or express language. Look at the picture. Okay, they can't speak, they can't write, they can't read, they don't understand. Now, if it's receptive, then the damage is to the Wernicke's area. You'll see this with some alcoholics because they have something called Wernicke's encephalopathy. So when you see someone that's really, really drunk and the police stop them, what can't they do? What do they make them do? Get out of the car and do what?
Make them
To
walk a
walk in
straight
a
line.
straight line.
Okay, but before they walk, you ever notice how many times the officer has to explain to them what they're supposed to do?
Yeah.
Yes.
And they can't understand the directions, right? They do the directions all wrong. So it's not even that they just can't walk. They cannot follow the direction because they don't understand. Expressive is about being able to say it, being able to express it. That is damage to the Broca area. And then global is a combination of both. That would be both the Wernicke and receptive. Okay, so expressive is when the Broca area is damaged and they'll have difficulty expressing what they want to say. With receptive, they have difficulty understanding what is being said. And with global, it's both. You need to know which one affects which area, okay? So expressive is Broca, receptive is Wernicke. And then I try to give you a little example over there. Okay, so Alice's husband is speaking to her. She had a stroke and she cannot understand him. That means Wernicke is broken. In the Broca area, expressive aphasia, Martha had a stroke involving Broca. She knows what she wants to say, but she can't spit it out. And global is both. All right, dysarthria. This is when the motor function is affected. We'll see this in things like ALS or Lou Gehrig's disease. The words cannot be articulated because the motor movement is damaged. And this can be from damage to the cranial nerve or muscle impairment. But they won't be able to clearly articulate the words because the muscle movement there isn't working correctly. It also can affect their respiratory, their vocal cords, their tongue.
Miss Sue, would that be considered locked in syndrome too? Or locked
No,
in?
no.
No.
Locked in syndrome is going to be where, so with locked in, they can't talk or move. These people can move. They could talk. It's just that you're not maybe going to understand what they say. The speech is going to
Okay.
be mumbled, okay, or quiet because they don't have the muscles to produce it. With locked-in syndrome, that's a brain injury.
Or brain. Okay.
This is more about, it could be neurological, but a lot of times it's also muscular. So it's
Okay.
really going to be more neuromuscular here because the motor function from that cranial nerve. All right. And then language disorders. So agraphia is inability or impaired writing ability. All right. And think about Alexia, okay? The loss of ability to recognize words you could once read. But also, I try to use the example when you call Alexa on your in your house, right? And you're in the other room or something and you're trying to say something and Alexa can't recognize what you're saying and it does something different. Or if you don't speak, pure solid English, Alexa might think you said something totally different if you have some sort of an accent. Has anybody experienced that?
Yeah.
Okay. Agnosia, this happens to people with dementia. So look at the example on the left. This is the one I usually use. So you notice when you go into the nursing home, sometimes you'll give your client that has dementia a toothbrush or a comb, and they don't know what to do with it. Or they might take the toothbrush and start trying to comb their hair. And you're like, Miss Jones, what are you doing? Right? You seen it?
Yes.
Yes. Okay. Or they don't know who you are. They don't recognize you. You'll see this in a lot of people with dementia, and the family gets really upset. How's she not going to recognize her own daughter? She has no control over that because of what's happening in the brain. All right, seizures. So with seizures, you have your definition. I would know that. Okay, spontaneous or excessive discharge of neurons in the brain. And what causes it? All right, a lot of things could cause it: inflammation, hypoxia, bleeding in the brain. Focal means that it happens right in a specific area, but focal seizures can become generalized. Usually with the focal, you're going to see involuntary repetitive movement or abnormal sensations. We call those an aura. So sometimes you'll see the expression on the person's face change, and you might see them like lip smacking or excessively smelling or staring into space. Sometimes they might feel nauseous or irritable or have some muscle twitching before the seizure occurs. And once they have the seizure, okay, depending on what type they have, some things that you'll see are things like temporary confusion, sitting and staring in space, uncontrollable jerking, loss of consciousness, cognitive emotional symptoms. All right, so now we were talking about the fluid in the brain, all right, and things can affect that fluid. Tumors, other things that happen within the brain can affect it. And they can develop what we call increased cranial pressure. What are we going to see with that? Okay, so you have to know this and what symptoms. So definitely we'll see a change in the level of consciousness. All right. At first, the body is going to try to compensate. But if it can't, all right, it's going to cause some other things to happen. So when the body can't compensate, the client develops hypoxia. And that triggers vasodilation in the arteries. Okay. And the body is going to try to improve blood supply to the brain. That is going to cause more fluid to go in the skull. And at first, it's effective. All right. But it's going to increase the cranial pressure there. And so as a result of that increased cranial pressure, we're going to see a decrease in the level of consciousness or a decrease in the responsiveness, which your book refers to as lethargy. Now, other signs we'll see, early signs of increased cranial pressure, are going to be a severe headache. And that's because of stretching of the blood vessels in the brain. That projectile vomiting that occurs without food. That's because of pressure stimulating that emetic center in the medulla. Papilla edema from increased cranial pressure and swelling of the optic disc. That pressure will put pressure on cranial nerve 3, and that's going to affect the size and the responses of the pupils. So sometimes one pupil, wherever that lesion is, can become fixed and dilated. If the pressure continues to increase, both pupils will become what we call blown. You guys have heard that expression, where the pupils become fixed and dilated. Other things we might see are droopy eyelids and nystagmus, okay, where the eyes move all over the place in a rapid abnormal movement because of stimulation to the upper eyelid. We'll see a decrease in the heart rate and a widened pulse pressure. What is the pulse pressure?
Systolic minus the diastolic.
Right. So what happens here is a lot of times systolic will go up, but not necessarily a change in the diastolic. We'll see Cheney-Stokes. That's irregular breathing. And you're going to lose some of those brainstem reflexes because of the changes of the pressure that's happening there. Oh, what happened there? Where were we at? Okay. All right, so brain tumors, these are a collection or a mass of abnormal cells in your brain. Remember, the brain is very rigid. Any growth in there is going to cause a problem because it's restricting an already small space, and your bone cannot move or adapt to that. Brain tumors can be cancerous or non-cancerous, so they can be malignant or benign, and it doesn't matter which one because they cause pressure in your skull to increase. And that can cause brain damage and be life-threatening. So a lot of times a focal or a generalized seizure will be the first sign of the brain tumor. Early morning headaches that cause increased cranial pressure. Vomiting. Why do we see vomiting?
Pressure on that emetic center in the medulla.
Okay, good. Why do we see lethargy? So that's a decreased response, right? Why do we see that?
Uh,
Remember, your reticular activating system is there, and
I
that's
was
your arousal system, right? So you're not easily aroused here because of pressure on that. We can see irritability, personality changes. Go ahead. Somebody have a question? And these brain tumors, a lot of times, will cause death before they start to cause general effects because of the changes inside that space that they're making. All right. Before I go into this, I really want to talk to you guys about the circle of Willis. All right. So the blood is supplied to the brain by the internal carotid arteries and the vertebral arteries. All right. So we have a left and a right carotid artery. We have the carotid sinuses, and there's receptors there. Now, those receptors will signal changes in the blood pressure. And then remember, we talked about chemoreceptors, and those are looking at changes in your pH and your oxygen levels. At the base of the brain, the carotid arteries divide, and one will go and supply the frontal lobe, and one will join the vertebral arteries, okay, to form what we call the basilar artery. And that is going to go up to the brain stem and the cerebellum. Now, what you really need to know here is that they join together through a process called anastomosis, okay? And they form what we call the circle of Willis. All right. And so this circle of Willis will branch into arteries that supplies about 80% of the cerebrum. Now, it helps us form what we call collateral circulation here, because if someone has like an impairment, okay, in a source of blood, then the circle of arteries can help support by bringing blood supply in from another area. So the main function of the circle of Willis, okay, is to provide collateral blood flow between the anterior and posterior arterial systems in the brain. And it provides us with an alternate blood flow between the right and left cerebral hemisphere. The circle protects the brain from ischemia and stroke in cases of vascular obstruction or damage. So that's the main thing that you need to know about that blood supply. All right, the blood flow in those cerebral arteries is constant. The brain cells constantly use oxygen and glucose, and they don't have very much storage capacity. Autoregulation, which is increased by carbon dioxide levels or decreased by pH in the blood or decreased blood pressure in an area of the brain, will result in local vasodilation. So these baroreceptors that I just talked about that are controlling the blood pressure, and chemoreceptors, which you know monitors for the pH and the oxygen levels, are protecting the brain from any damage from either abnormal blood pressure or pH levels. Now let's go back to that other slide. All right, so when one has a stroke, it depends on the location of the obstruction and the size of the artery that is involved. With that collateral circulation we just talked about from the circle of Willis, sometimes it can diminish the size or the area of the stroke. Usually with a stroke, we'll see some lack of voluntary movement or sensation on the other side of the body. It could be flaccid paralysis initially, and then later they can develop things like spastic paralysis. So the slide here shows you, what we would see if someone was having a stroke. And so we use that FAST acronym to look at them, right? So a lot of times they'll have a sudden onset of numbness or weakness in the face, the arm, the leg, or one side of the body. Sudden confusion or difficulty speaking or understanding. They may have a problem with the vision in one or both eyes, trouble maintaining their balance or their coordination, or they might feel dizzy, or a severe headache with no known cause. So things that put them at risk for this are diabetes, high blood pressure, SLE, too much cholesterol, atherosclerosis. TIAs are a precursor for a stroke. Increasing age, obstructed sleep apnea, heart disease, or taking oral contraceptives and smoking cigarettes. So, a stroke is an infarction of the brain tissue from a lack of blood. Necrosis can be an outcome from ischemia, all right? Or we could have a hemorrhagic stroke, which is where we're bleeding, okay? And that could lead to things like increased cranial pressure. One of major cause of strokes is an atheroma, okay? It can develop in the large arteries like the carotid and cause narrowing of that area by plaque. This can also cause a thrombus to form on the plaque, and eventually it breaks off and it can lead to a TIA or a stroke. Now, a sudden obstruction caused by some emboli lodged in a cerebral artery is the second type of stroke. That's a cerebral embolus. You also have intracerebral hemorrhage. This is from a rupture of the cerebral artery. A lot of times these clients will have severe high blood pressure. Hemorrhagic strokes are often more severe and destructive because now you have fluid or bleeding in the brain. The blood itself can cause irritation and damage because it's in a part where it doesn't belong. It can cause increased pressure in the brain. That can cause things like vasospasms, electrolyte imbalances, acidosis, edema. So the types of strokes are either the occlusion by the erythroma, a sudden obstruction caused by an embolus lodging in the artery, or intracerebral, where we have a rupture of the artery in a patient with severe hypertension. And because of that, we have bleeding. So again, it can be either from an obstruction or from a bleed. TIA, you have to know the difference between TIA and a stroke. With TIA, the manifestations are directly related to where the ischemia occurred. These people remain conscious. So they might have a short episode of impaired function, muscle weakness in an arm or a leg, sometimes a visual disturbance. They may have transient aphasia, so where they have some difficulty for a little bit, but it resolves, or confusion. This can last usually a few minutes or longer, sometimes up to an hour, but rarely over 1 to 2 hours. And then once it's over, the signs disappear. If they continue to have these, then they're definitely considered a warning that they might have developed some sort of obstruction because of their atherosclerosis. With a stroke, okay, they're going to have more long-term effects. It's not temporary. It may take time for the effects to return. Sometimes they do. Just because they had a stroke doesn't mean that the symptoms will last forever. But sometimes they do lose function in certain areas and they don't recover from the loss of that function. So we talked about the types of stroke, okay? Next, we're going to talk about cerebral aneurysms. So these are usually going to be at the points of bifurcation on the circle of Willis. That means where the two arteries are coming together. Okay, because that's going to be typically an area that's a little bit weaker. All right. So think about that when let's say you have a solid pole, all right, in the bathroom that you put up to hold your shower curtain versus a pole that has two pieces coming together in the middle, or even a curtain rod. So when you have one solid curtain rod and you put it up with a solid structure, usually you can hang pretty heavy curtains on it and it doesn't bend or dip in the middle. Sometimes when you have two curtain rods together and your curtains are too heavy, what happens? It bends or it pulls down in the middle. Okay, where those two rods come together is a weaker point. And that's the same thing you see at the circle of Willis. You have these weak points of bifurcation where these arteries come together. You can also have a weak area in the artery itself, and they can form these berry aneurysms, which you see they bubble out. All right. And a lot of times they're aggravated by high blood pressure. Sometimes they're small, they're asymptomatic. Sometimes people can develop a slow bleed from them and they can cause a headache. If it ruptures suddenly, it can cause death. And before the death, we'll see like severe blinding, headache, vomiting, because they'll have severe increased cranial pressure first and then the death. So with the aneurysms, what would you see? Loss of vision, headache, intermittent periods of dysfunction, nuchal rigidity from meningeal irritation. So your meningeus has cords coming down that connect to your spinal cord, okay? And when someone has meningitis or they have a problem like this, they become tight. And when you pull on them, it causes pain in your neck and your back. It's like a tight cord. Vomiting, seizures, loss of consciousness. And then if it is a massive rupture, then they can die from it. All right, next is meningitis. So this is an infection usually caused by a virus or a bacteria or a fungus. Any age group is susceptible, but we'll see this a lot more in places where people are housed together, like colleges, institutions. Different age groups are susceptible to different organisms. Okay. So for kids and young adults, and I would know this, it's spread by respiratory droplets usually. So sneezing, coughing, even talking. And they'll usually have Neisseria, meningitis, or meningococcus. Any person in close contact should receive prophylactic treatment. And this usually spreads in late winter or early spring. All right. A lot of meningitis is going to be bacterial. So it's this purulent exudate. It covers the surface of the brain. The exudate gets into the cerebral spinal fluid and causes the blood vessels on the surface of the brain to look dilated. A lot of times people get meningitis from another infection. So they can get it secondary to sinusitis or otitis, like an ear infection, or from an abscess in a tooth. There's different types. Aseptic, that's what Nurse Sarah had, and that was from an insect bite. There's viral, okay? And that usually comes from some sort of infection or bacterial. All right, the viral often comes from mumps or measles. Bacterial will be something like what a baby gets. So baby might get it from E. coli, especially if they have a neurotube defect. So what happens? The microorganism gets in the brain through the blood or nearby tissue. It gets into the cerebral spinal fluid. Then it spreads throughout the brain. There's no focal signs because there's no localized mass of infection. So the inflammatory response will be the same as what we would see in increased cranial pressure. The exudate is going to be present in cerebral spinal fluid. So it's probably going to be cloudy. The blood vessels on the surface of the brain will start to dilate. On the bottom here, I put the most common causes, okay, for the different age groups. So for babies, it's E. coli. For young children, Haemophilus influenza. For children and young adults, Neisseria meningitidis or meningococcal. And for elderly people, Streptococcus pneumonia. Now, if they had meningitis, what would you see? Fever, stiff neck, headache, photophobia or increased sensitivity to light, confusion. These two signs, Brudzinski and Koenig. Okay, so Brudzinski, think about B. They can't bend their neck, hips, and knees because when they do, it causes severe pain. And that's because that meningitis is going from the meninges down that spinal cord like a tight rope. The Koenig sign, where they can't extend the knee because they have pain when the hip is flexed at a 90-degree angle. In babies, sometimes with meningitis, you'll see a petechial rash. So that is going to be, let me see if I could show you a picture of that. What is that? 129. I would behoove you guys to watch chapter 14 because I have the whole chapter recorded. All right, because there's a lot of things I won't be able to cover today that you should just have a little bit of an understanding about, and it'll reinforce some of the things that we went over today to make it a little more clear for you if you have any concerns. All right, but if you see the baby here, can you see the picture?
Yes.
Okay. All right. The baby will develop this petechial rash with the meningitis. So you need to be aware of that as well. Some adults will develop it also, but usually means little hemorrhages, little areas of bleeding. Again, E. coli is most common with the babies, and usually they have a neurotube defect, and that's why we see it there. Because with the neurotube defects, they can have an open area on the back. Okay, and if it's not covered and kept sterile, then things can seep into it, like when you change the diaper, like E. coli. All right, with children and young adults, it's the Neisseria meningitis or the meningococcus, and with the older adults, the streptococcus pneumoniae. What are the signs and symptoms? Okay, I put them on that other slide, but here you go again. This is right from your book.
And Miss Sue, when you would say like for the Koenig and the Brudinsky, you would like if you were charting it, you would say they have a positive one, right? If
Correct. Positive
okay,
for Koenig sign, positive for Brudzinski's, or
okay.
negative.
And it would be
Yeah.
negative if they can perform those without issues, right?
Correct. If they're not experiencing any pain.
Okay.
See, and you guys don't need to know treatments and diagnostics, okay? They're not going to ask you about that. So don't waste your time on it. You'll have to know those pretty soon, not now. All right, so brain abscesses, they can also develop. This is any localized infection. It usually happens in the frontal or temporal lobes and will have necrosis of the brain tissue, and the surrounding area will be edematous. Sometimes medical history can tell you about it. Abscesses will come from things like infections in the ear, the throat, the lung, the sinuses. A lot of times they'll have focal signs that indicate neurological deficits, increasing cranial pressure, and common organisms for these are staph, strep, and pneumococci. Encephalitis. So this is infection of the parenchymal or connective tissue in the brain and the spinal cord. Usually comes from herpes, some sort of tick. It can cause permanent damage to the brain, necrosis, and inflammation. They might develop meningitis from this. Okay. And then early signs are going to be headache, stiff neck, lethargy, vomiting, seizures. With encephalitis, a lot of times they'll have flu-like symptoms. Now, Western equine encephalitis, this is an infection, an aboviral infection from mosquitoes. So I think about this as my Disney World encephalitis because it usually happens in the summer months. It's common in kids and it's spread by mosquitoes. If you go to Disney World, okay, that's what it is. It sits in the swamps. It's hot. It's humid. It's a place for these kids to develop encephalitis if they get bit. We'll see people sometimes coming back in the ER. Their kids have this, and we'll ask them where they've been, and Florida. Okay. St. Louis encephalitis. The only thing your book says is what I have here. This is found in the US and it affects older adults more seriously than young ones. Okay. And then West Nile virus. For this one, we see this in New Jersey a lot. This is going to be a bird and a mosquito. And this is Flava Flava. Y'all know Flava Flava. He lives in North Jersey. He's a rapper.
You talk about
So,
Flavor Flav with the big clock.
yep.
Well,
Flava Flava. Flava Flava. Just saw him in the summertime. Okay. So it's a flava virus spread by mosquitoes and birds. So the mosquitoes eventually attack the birds. The birds die from it. We'll find dead birds. And when we analyze, this is what they have, West Nile virus. Some other types of encephalitis. So Lyme disease. This is caused by the Borrelia burgdorferi. Now, with this one, usually what we'll see is the bullseye rash. Okay. And then they'll develop a sore throat, fever, headache. It can affect your heart and your joints. So if you had Lyme disease when you were young, you may have problems with your joints when you get older. Or if someone went with an untreated Lyme disease, then you might see some of these other symptoms develop. Herpes encephalitis. This spreads from herpes 1, and it causes necrosis and hemorrhage in the brain. And then the amoebic meningoencephalitis. This is caused by the amoeba Naegleria fowleri. I think we talked about that last week. This lives in warm water. Okay, this can be fatal. We don't see it that often, but there were 2 or 3 infections last summer of this. Inflammation and swelling of the brain. Rabies. Okay, this is a virus. This is transmitted by a rabid animal. The virus will go along the peripheral nerves to the central nervous system. I would know the symptoms of this. Okay, it's going to go to your salivary glands. So that's why, think about the bite. What is where those teeth are? Those salivary glands, that infected saliva. The infected saliva is part of that rabies infection. So the virus goes into your salivary glands, and because of that, you're going to have a problem swallowing, and you might even be fearful of fluids. And a lot of these people will die from respiratory failure or death. That's why, people doing stupid stuff on TikTok, okay? Why are you letting your child hold things like a skunk or a raccoon? That's who carries rabies. Raccoons don't come out in daylight. If they're out in the daylight, they may be rabid because the animal's acting strange for where it's supposed to be. And squirrels are just dirty. All right, tetanus is another one. A lot of times this is going to be in the soil. And the bacteria is Clostridium tetani. So usually we get the tetanus from some wound, some cut, some burn. So whenever you get an injury like that, the doctor was always going to check to make sure your tetanus shot is up to date. If it's not, they're going to want you to get vaccinated. The bacteria produces a toxin, and that toxin is going to attack the central nervous system. It's going to lead to things like muscle stiffness, spasms, pain in the jaw and the neck. And opisthotonus is that position that you see that guy in. Okay? A lot of times you'll see that in babies, but there's an adult showing you it. It's causing that arching in the back. Again, tetanus can be prevented by just getting your vaccination. So, if you step on a dirty nail, you have a problem, they're going to check you. Even before some surgeries, right? They want to make sure right, with that surgery that you're going to be safe. Because if you got cut with a dirty knife or something, then you could develop tetanus. And believe me, it's not unheard of to have a dirty knife in the operating room. It's not common, but it's also not unheard of. Poliomyelitis, infantile paralysis. This is part of the polio virus. Okay. Now, at one time, there was no threat of this, but it is highly contagious through direct contact or oral droplets. I would know that. It can enter the central nervous system. It will attack the spinal cord and the medulla, causing flu-like symptoms, but eventually respiratory and paralysis and respiratory failure. These clients will have a fever, headache, vomiting, stiff neck pain, and flaccid paralysis. And by the way, the United States and several other countries keep a certain amount of this on board for biological warfare. Herpes zoster or shingles. This is caused by the varicella virus in adults. It usually happens after someone's had a chickenpox infection. It affects the cranial nerve or a dermatome, which means it runs along one line. And some of that stuff about dermatomes I didn't cover. So I want you to really watch that video because it's going to talk about all that. I don't have time to cover it all today. This is a huge chapter. It takes about 3 or 4 hours to cover it. This can result in pain, paresthesia, and a vesicular rash. It usually runs along that nerve line. So if you notice people have it, it'll run like across their back, across their chest, or up the side. And it can cause them to have pain for years. But that virus, once they have the chicken pox, okay, that virus will lay dormant in the ganglia. And then when stress or something happens, it's reactivated. Post-polio syndrome. This occurs about 10 to 40 years after someone recovers from the original polio. It leads to progressive, debilitating fatigue, weakness, and atrophy of the muscles. I would know this next one, Ray's syndrome. We really don't know the cause of this. However, we see it in children that have had a viral infection that were treated with aspirin. The virus usually appears 3 to 5 days after the onset of the first viral infection. It causes pathological changes in the brain and the liver. They'll develop cerebral edema, increased cranial pressure, causing issues with brain function, high ammonia levels because of the liver dysfunction. The liver enlarges, develops fatty changes, and progresses to acute failure. Another thing I would know about this. So you want to know, what is it? Okay, it's linked to that viral infection in kids with aspirin. It causes changes in the brain and the liver. What kind of changes? So enlarged fatty liver with liver failure, impaired brain function from cerebral edema. Now, fulminant, if you look on the slide, fulminant hepatitis means your liver is fully engaged with that hepatitis. It's a severe infection. Guillain-Barré syndrome. Okay, the red is from your book. This is post-infection polyneuritis. It can be from idiopathic polyneuropathy. What does idiopathic mean?
We don't know
It's
what
like
it is.
unknown.
All right. I say the idiots don't know why we have it. Okay. And iatrogenic is what?
That's something else.
Caused by something else in the body.
Mm-hmm.
All right. So here with Guillain-Barré syndrome, we have an inflammatory condition of the peripheral nervous system, and it usually starts in the lower legs and moves its way up. So we'll have progressive muscle weakness, lack of reflex responses. Eventually, they develop flaccid paralysis, and it'll continue to move upward and affect their ability to breathe, their face. We have demyelination of the nerve fibers. They're going to ask about that if they ask about this, likely. So myelinated nerve fibers means that they're insulated basically with that myelin sheath. And that myelin sheath allows those signals to transmit really quickly. When we demyelinate it or remove the sheath, that's going to affect the ability of signals to transmit. So, factors are going to be viral infections. That's usually what we'll see in this person right before they develop it. They could get a vaccine that could cause them to develop it. Or polyneuritis that could cause them to develop this. All right, you need to know the difference between concussion and contusion. All right, so concussion is considered a mild traumatic brain injury. It's considered reversible with brain function, and it comes from a mild blow to the head that causes sudden excess movement of the brain, disrupting the neurological function and leading to a loss of consciousness. People can have amnesia or memory loss or headaches after a concussion. Usually they recover with no permanent damage within 24 hours. However, if they have recurrent concussions like Muhammad Ali, one of those boxers, that can lead to progressive permanent brain damage. The contusion is bruising of the brain tissue, which sometimes leads to rupture of the small blood vessels and edema from some sort of blunt trauma to the head. All right, so I would know the differences between these. All right, subdural hemorrhage, that's that bleeding in the outer covering of the brain between the dura. Epidural hemorrhage, bleeding inside of the skull and the dura. And then intracerebral, which is bleeding directly into the brain tissue. Okay, and then it lists some of the possible causes. All right, depressed skull fracture. This is where we have a piece of the bone that's broken and pushed down below the level of the skull. And because of that, it's compressing the brain tissue. Here, it causes impairment of the blood supply and causes additional pressure on the brain. You should know these types of fractures, okay? Basilar, this happens at the base of the brain. And remember, I said sometimes we have leakage of that spinal fluid, okay? We put the gauze underneath the nose or the ear, and that halo ring tells us that we have cerebral spinal fluid leaking. The basilar skull fracture is the most serious type. Here you have a broken bone at the base of the skull. And these clients will have what we call a battle axe or raccoon eyes. So both eyes are blackened, or battle axe is when they have bruising around the mastoid process. You'll also see clear fluid from the client's ears and nose, and that's caused by a tear in the protective covering of the brain due to the trauma. Contracoup. So we'll see this in shaken baby syndrome, or if someone's in the car and they rear end somebody and your face goes into the windshield and then back out. So the area of the brain contralateral to the site of the direct damage is injured. The brain bounces off the skull. Can be secondary to acceleration or deceleration injuries, in which the skull and the brain hit a solid object, causing the brain to rebound against the opposite side of the skull. All right, next is autonomic dysreflexia. this is a serious complication caused by a sensory stimulus that triggers a massive sympathetic reflex response that cannot be controlled from the brain because there's a spinal cord injury. The trigger is usually something like a distended bladder or a decubitus ulcer. It can also be things like constipation, a sudden change in the temperature in the room. So they develop what we call autonomic dysreflexia. This can be life-threatening, and we have an abnormal or overreaction of the autonomic nervous system to some painful sensory input. And again, this is what we see after certain spinal cord injuries. So a sensory stimulus to the sympathetic nervous system below the level of injury can stimulate the entire chain of sympathetic nervous system ganglia, causing excessive vasoconstriction. This causes a sudden increase in blood pressure, severe headache, and visual impairment. Bradycardia will accompany the syndrome because the baroreceptors in the body see the blood pressure as being high. And so they respond through the vagus nerve system by slowing down the heart rate. The excessive vasoconstriction cannot be reduced through the heart or through that cardiovascular control center in the brain. Okay. And because of that, we're going to have to intervene here and remove whatever's causing that stimulus and probably have to give some sort of medication to lower the blood pressure. Otherwise, they can die. All right. So it's usually caused by a spinal cord injury. Usually the brain would be able to send a signal on through and control things below that injury on the spinal cord. But because that injury is there, the brain is not able to control it. All right, this is just, there's different types of head injuries, closed and open. You should be aware of the different types of head injuries. All right, primary brain injuries. These are direct injury that comes from some sort of laceration or crushing of the neurons, rupture or compression of the cerebral blood vessels, or damage because of some inner surface area of the skull becoming too rough or irregular, causing the brain lobes to move against each other. Secondary injuries are when we have something like cerebral edema or hematoma or ischemia, and it causes another issue in the body. Again, I would know these different types of injuries. Epidural hematoma, that's that bleeding between the dura and the skull. Subdural hematoma, this develops between the dura and the arachnoid, and the hematoma can be acute or subacute. Here we have a tear in the arachnoid, and it's allowing the cerebrospinal fluid to leak there, causing additional pressure. The subarachnoid hemorrhage. This occurs between the arachnoid and the pia, and it's associated with traumatic bleeds from the blood vessels. And then intracerebral hematoma, which is from contusions or shearing injuries. And a lot of times this won't develop right away. It'll develop a few days later. The hematoma itself is a collection of blood in the tissue. It develops from ruptured blood vessels right after an injury. Some of them will be delayed, and sometimes they can develop after surgery. Chronic subdural hematomas can occur in older adults with brain atrophy. A tear in the arachnoid allows the cerebral spinal fluid to leak into the subdural space, creating additional pressure. In all types of hematomas, the bleeding leads to local pressure on the adjacent tissue and increase in the intracranial pressure. Most hematomas will disintegrate in about 7 days after the injury. When the blood accumulates slowly, the blood cells will undergo hemolysis, causing the cells to break down, and that can cause a change in osmotic pressure, pulling more fluid, more water into the area, increasing the size and the pressure of the mass, and increasing the increased cranial pressure. All types of hematomas can lead to increased cranial pressure and additional pressure on the adjacent tissue. Sometimes people with head injury will show focal signs of increased cranial pressure, but also they might have seizures, which is a focal sign. They can have cranial nerve impairment. This is seen in people that have those basilar fractures. They can have leaking spinal fluid from the ear or the nose, and that's called otorrhea or rhinorrhea. Any damage to the spinal cord can be temporary or permanent. The nerves in the spinal cord do not undergo mitosis, but the axons can sometimes regrow. Laceration of nerve tissue by the bone fragments usually results in permanent loss of conduction in the affected nerve tract. Now remember, those nerve tracts are bringing signals to and from the brain. Any complete transection or severing or crushing of the cord can cause irreversible loss of all sensory and motor function at or below the level of injury. So they're talking about the spinal cord here. If it's completely severed or crushed, we'll see irreversible loss of all sensory and motor functions at or below where that injury occurred. If we have a partial severing or a partial crushing, then some of the area may recuperate. Vertebral fractures are classified as either simple, meaning we have a single line break, compression, where we have crushed or shattered bone in multiple fragments. They like to ask about that one. A wedge, which is a displaced or angular section of bone. A dislocation, they like to ask about that too, where the vertebrae is forced out of its normal position. Spinal cord injuries are often unstable, and we need immobilization right away so that we don't cause additional damage. We can also see hyperextension or compression of the cord. Cervical spinal injuries can come from hyperextension or hyperflexion of the neck. Bruising is irreversible damage that involves mild edema, minor bleeding, temporary impairment of the nerve impulses, so they're not able to conduct. If the spinal cord is compressed, we have to relieve that compression quickly in order to maintain the adequate blood supply. Any prolonged ischemia or necrosis can lead to permanent damage. Edema and hemorrhage may extend to several segments above or below the level of injury. Edema and hemorrhage can extend several segments. I just said that. Damaged tissue also will release mediators like norepinephrine, serotonin, and histamine. So we can see things like vasoconstriction, ischemia, necrosis. Also, enzymes are sometimes released there that are destructive and lead to additional inflammation and necrosis. By using the dermatome map, you'll see that in your book. Okay, that can help us determine the degree or damage and the person's ability to recover. Spinal shock, I would know this. Okay, this comes from a spinal cord injury, and usually we'll see the impairment below the level of injury. things like loss of function leading to paralysis, loss of reflexes, like your anal sphincter tone, your bowel, and your bladder control. Some of these people can develop a persistent penile erection called a priapism, where the erection won't go down. And with spinal shock, it's really a combination of reflex and neurological issues. Okay, so either hyporeflexia, where we have a reduction in the reflexes, or areflexia, where we lose the reflexes and the autonomic dysfunction occurs. With autonomic dysfunction, we'll also have problems with the autonomic nervous system. And remember, those control automatic things in the body, like your blood pressure and your heart rate. So before we were talking about autonomic dysreflexia, and again, the body's not able to control because of the level of the injury. Recovery from spinal shock, this is a test question all day, is indicated by the return of the reflex activity below the level of the injury. So it was flaccid, but now it's returning. All right, we're going to go for a few more minutes. I got a couple more things I want you guys to see. Myasthenia gravis. This is a chronic autoimmune condition that affects the muscles and the nerves. And what we'll see is a sudden onset of fatigue and muscle weakness that gets worse after activity, but improves with rest. Remember, acetylcholine is going to be that main neurotransmitter at the neuromuscular junction that regulates your muscle movement. Okay. Muscle weakness in the face, the eyes, and fatigue develops quickly when the muscles are being used. They'll also develop diplopia and ptosis, meaning the eyelids are droopy. Chewing and swallowing become harder. Again, it's affecting the muscles. So we have muscle weakness. It will progress. These clients become at risk for aspiration. The head will droop as the neck muscles become involved. The arms become weaker, and it's hard for this person to do things like combing their hair, brushing their teeth. Huntington's disease. This is an autosomal dominant trait. It does not manifest until midlife. Progressive atrophy of the brain occurs with degeneration of the neurons in that basal ganglia. So remember, I said basal ganglia is highly responsible for what? Remember, I was
The
talking about
response and alertness to things.
movement.
Movement.
Remember, I was talking about the psychotropics, the extrapyramidal symptoms, and the tardive dyskinesia. So the basal ganglia are responsible for movement. Okay. And this all happens in the frontal cortex, which is also responsible for logic, thinking, and memory. So acetylcholine is also reduced in the brain here. And that's going to cause problems with mood swings, personality changes. Because the acetylcholine is depleted, that can cause, and the basal ganglia is affected, that can cause rapid, jerky movement in the arm and the face. Okay. Again, memory impairment. So difficulty learning new information, losing those problem solving skills, poor judgment. All right, let's look at a couple of questions real quick. Which of the following choices is considered part of the necessary requirement to declare brain activity?
B
I'm
and
sorry, to
C.
declare brain death.
B and C.
Okay, B, no activity on the E. Oh, I'm sorry. B, absence of all reflexes. C, no spontaneous respirations. What else?
I'll say A, B, C.
A.
Okay, A, no activity on the EEG. You're educating the client about transient ischemic attacks. What options are correct?
B.
B.
And actually, this is a
E.
Isn't it
select all that
A,
apply.
B,
This is a
E?
select all that apply. So what is not
E.
correct?
E.
E?
D is not correct.
B. E.
Okay, so D and E are not correct, right? So then the rest of them must be correct.
Yes.
Okay.
Mm-hmm.
All right. A patient's MRI shows damage to the cerebellum a week after the patient suffered a stroke. What assessment findings would correlate with the MRI finding?
Balance impairment.
Balance impairments. Your patient had a stroke, has issues with understanding speech. What type of aphasia is this patient experiencing, and what area of the brain is affected?
It would
Can't
be
understand it.
B.
receptive
B.
and Wernicke's.
B.
Okay, receptive because he can't understand it or comprehend it. You're assessing a patient's pupil size and vision after a stroke. The patient says they can only see half of the objects in the room.
A.
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 Okay, good. Which of the following statements best describes contra-coup pattern?
C. On the opposite side. Oh, D.
Okay, the brain is injured after it bounces off the skull.
That's like the bouncing baby thing. The shaking baby.
Correct. The head bounces back and forth off the skull. That's what causes the damage.
But can you go back to the definition of it real quick?
To the definition of contra-coup.
Yeah, what it said at the end, like the or not like in the thing.
No,
I meant that question, like
the question. The
the
rationale.
reasoning. Yeah, the rationale.
Yep, that's it.
Yeah, that's it.
And then when you put the answer, it comes up.
Okay. Okay.
All right. The nurse overheard the doctor stating one of her clients is in a vegetative state. What was the doctor referring to?
B.
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 What major function is the limbic system responsible for?
C.
C. C. Mhm.
The nurse overheard her doctor saying one of her clients is in a vegetative state. We just did this one. Nurse is caring for a client with increased cranial pressure as a result of a head injury. The nurse would note which trend in vital signs?
Increasing.
1.
Everything would be depressed. So all the low stuff. I guess 3.
Okay, everything's not
Good.
depressed.
I
However,
thought
what
you
is
had it.
true?
It's
What
up.
is true? How's the pulse going to be?
Isn't it elevated?
Yes, increased blood pressure.
Yeah.
You sure? You sure the pulse is going to be increased?
The heart
No,
rate
it's
is
gonna
decreased
Oh no,
because the
it's gonna
vessels are
be
widening.
decreased because the pressure on the
Okay,
The
so if you know
brain.
the heart rate is going to be decreased, then what can you eliminate? You need to use what
Venous
you
and
know to
blood.
get to what you
you
don't
can
know and stop
eliminate
guessing.
Or
You
Because
can
guessing,
eliminate 1 and
listen,
4.
listen, because guessing is going to get you in trouble on the exam. So, what do you know for sure occurs? Eliminate other options that is not true in. Okay, so you can eliminate 1 and 4.
I think you have an increase in respirations. Would it be 3?
Again, you're guessing. You got to
I
know.
thought it
Look it up. Look it up in your book.
wasn't.
Who knows what page it's on?
I'm scrolling now.
Okay.
Okay, it's page 343. Hold on. I have increased blood pressure, uh, baroreceptors, they increase the blood pressure and slow the heart rate, thus reducing. And then chemoreceptors respond to the carbon dioxide, causing a reduce in the respiratory rate. So then it's a decreased respirations, decreased heart rate, increased blood pressure.
All right, and increased temperature.
An increase. I just can't see the temperature, but
Okay. What are the signs of autonomic dysreflexia in a person with a cervical spine injury?
Two.
No.
Okay, 2 is right. This is all in your book, guys. All right, nurses evaluating neurological signs of a client in spinal shock following a spinal cord injury. Which observation indicates that spinal shock persists?
C.
Good. So signs of that increasing cranial pressure, guys, are going to be decreasing level of consciousness for sure. The temperature might not be listed in your book, but that is one of the things that happens.
signs. Okay.
All right. Client is admitted to the hospital of Guillain-Barré syndrome, which past medical finding makes the client at risk for the disease.
That is the
There's one.
4,
Okay,
the
good. Whoever
infection.
said 1, a viral infection or a vaccine, okay, some autoimmune condition. Oh, shit. It
Yeah, I
said
said
5 years
4.
ago. It said 5 years ago. That's why one was wrong. Okay. All right. We did that one. Client. Oh, we did that one. Here you go. One more. Myasthenia gravis occurs when the antibodies attack blank receptors at the neuromuscular junction, leading to this.
B.
B as in boy.
Yep, B.
Okay. B as in boy. All right. That's it. That's it for today.